This is the Cardiac Arrest Management Review and Practice lesson. We'll review and practice proper chest compressions for all patient age groups. We'll review and practice how to integrate the AED into the care of all age group of patients, and we'll particularly talk about how to handle those cases where the patient does develop a pulse after some of our treatment and how we manage the AED from there. Then we'll review and practice airway and breathing management during cardiac arrest and review how to deal with that situation when you're by yourself, or then when there's teams of 2 or 3 or 4 or more. We'll also review and practice management of a cardiac arrest that we think is from trauma. It's very difficult sometimes to determine whether a cardiac arrest is pure medical cause or pure trauma cause, but there are differences in the treatment of traumatic arrest. Mostly we simply go as fast as we can. And then we'll also talk about how to integrate the ALS ambulance crew, what their roles will be, what they're going to want to know when they come in, where they're likely to position themselves, and how we can do things to make the cardiac arrest most efficient. So compression rate's always 100 per minute, regardless of the age of the child, for infants, children, and adults. This Staying Alive song can play in your head. You can use the AED's metronome, but 100 beats a minute is what's correct. It's technically true that for newly born patients, it's a little faster than that, but we almost never encounter that. So think 100 times a minute. Faster is not better. The heart needs time to refill. So right at 100 is what we're looking for. You'll remember that we're looking for deep compressions, at least 1/3 of the chest depth. There's a lot of discussion about how many inches that is with various patients, but really it makes more sense just to remember that proportion. You want to compress the chest at least 1/3 of the way down. 1/3 to 1/2 is the official standard for American Heart, so we want to go at least 1/3 of the chest depth. And always allow full chest recoil. This is very important because it allows the heart to refill. And very much like we were talking about, don't compress too fast. There's not enough time to refill. We also need to allow full chest recoil for blood to flow back into the chambers of the heart so that it can be ejected with your next pump. This is a deal when you're trying to do CPR on the move. It's very difficult to brace yourself appropriately in the ambulance and be safe and still do effective CPR. There's a lot of concern about CPR on the move and how ineffective it is when we're doing manual compressions. Another advantage of the mechanical CPR devices, they don't really care whether they're moving or sitting still. And we should also switch frequently. Your first minute or two of compressions are your best minute or two. And it is not an ego thing. It's simply a matter of switching fresh people in. So as soon as we have adequate people to do that, we should position one on each side of the chest. And after every 2-minute cycle where there's a pulse check and a rhythm check by the AED, then we're going to switch compressors. We want to limit our interruptions in CPR. Just because you stop compressions, as soon as you stop compressions, the blood flow stops. But just because you restart compressions doesn't mean that the blood flow has gotten back to its normal. As a matter of fact, it takes another 10 or 20 compressions after you've restarted in order for blood flow to get back to where it was. Really good manual CPR is only moving about 25% of the normal blood flow anyway, and so we need to absolutely maximize all the effectiveness of that by limiting interruptions for airway and movement, removal of clothing, and those sorts of things. The ratio of compressions to breaths is sometimes confusing. Try to give you a couple of things to remember here and try to reduce the confusion. On an adult, it's always 30-2. Doesn't matter how many of you are working it. When you're by yourself, it's always 30-2. Only time it would be 15-2 is when there are 2 of you working a pediatric patient, an infant or a child. As far as breathing rates goes, faster is not better. It's harmful, and we still see this a lot in the field setting. A breath every 6 seconds is plenty. The problem with breathing more often than that, or breathing too deeply, is that it changes the pressures inside the chest and reduces the ability for the heart to refill. Faster is absolutely not better. It is absolutely important that we do a breath every 6 seconds. So give a breath count to 6. And then as far as continuous compressions, once an ET tube or combi tube has been placed and verified, then we should switch to continuous compressions. And so this means that You will breathe once every 6 seconds, and you will be breathing while compressions are going on. The breath can get into the chest when that ET tube or combi tube are placed properly. And then if you're working a code with the AutoPulse, device, the mechanical CPR device that Boone Hospital uses, can be set to continuous or to not continuous. And so make sure that you know which one's going on, and the AutoPulse will give you a couple of warning beeps, a couple of compressions ahead of time before you're supposed to give a breath. Most of the time we're going to be using a bag valve mask for ventilation. Anytime you're using a bag valve mask, you should always use an oral or a nasal airway, or two nasals, or an oral and a nasal. Any combination will work, but you need those airway adjuncts in place to help you maintain the airway when using a bag valve mask. That's why they're packaged together in the EMS packs. They should be used together. Flow the oxygen to that bag valve mask at 15 liters a minute. That's fine. If we're going to do pre-oxygenation for a minute or two prior to placing a combi tube or prior to the paramedics placing an ET tube, then we'll do pre-oxygenation. We can crank it up to 25. More is better in all cases. There's nothing wrong with using 25 liters per minute all the time, except it may cause us to run out of oxygen on a scene, although that seems unlikely. But anyway, more is better, just don't run out. And that bag valve mask, this is the key point from this screen in this slide. The bag valve mask is a two-person tool. American Heart says that. All the curricula say that. It's a two-person tool. One-person bag valve mask is generally ineffective. Maybe with someone with really good technique, large hands, and a very small patient, you stand a chance of having a good mask seal and decent ventilation. But other than that, it's a two-person tool, and we've got to stop treating it like it's a one-person tool. So we'll talk here in a minute about how to integrate that in and use that bag valve mask effectively to treat our patients. Switching now for a second to talk about AEDs, we should apply them only to pulseless patients. If you're not certain, start CPR and apply the AED until you can be certain. But once your patient develops a pulse during treatment, he may lose a pulse again, and so you don't want to take the pads off, but you need to disconnect those pads from that AED, or the AED will continue to prompt you to do CPR anytime it sees a rhythm that's not VFib. Some EKGs, matter of fact, any rhythm, pretty much, with the exception of VFib or a really, really fast VTAC or asystole, almost any other rhythm can present with a pulse or without, and the AED's got no idea whether the patient has a pulse. It's assuming that you would never have applied the AED to a person with a pulse, and so that rhythm, in the context of no pulse, it recommends that you do CPR. So we've kind of covered this before, but we want to hit it again. If you're in doubt, apply the AED and start compressions. Once you get your patient to develop a pulse, then let's disconnect the pads from the AED, shut the lid, and keep it close by, because that person will rearrest in many cases. And just realize that just because you may see a rhythm on the screen of the AED, or the AED may sense an organized rhythm, it doesn't mean that it has a pulse, and the AED must assume that there is no pulse, and so it's going to direct you to do CPR on patients with pulses. This is how we need to manage AEDs and pulses and rhythms. AEDs can't check pulses, they can only check rhythms. So what do you do when you're by yourself with a cardiac arrest patient? Well, your AED is your top priority. The most common rhythm that patients are in, heart rhythm that patients are in right after they arrest, is VFib. The treatment for VFib is a defibrillation from the AED. So in the case that they're in VFib, in a shockable rhythm, you've got to get that AED on. And then compressions are your second priority. And you'll see in a minute that when there's two of you there, right off the bat, one of you starts compressions while the other applies the AED. But if you're by yourself and you have to make the choice, then apply that AED as your top priority and be ready to start compressions. Ventilation is important, but it's not more important than compressions. And compressions in this case are not more important than an attempt to defibrillate. So you're going to put them in that order. Now, a bag valve mask, as we said, is a two-person tool, and by definition you can't use it when there's just one of you there. You may be able to use it when the second person arrives, and we want you to. But initially, that's what that pocket mask is still for, and the pocket mask ventilation is going to be your best bet. but focus on the AED and the compressions. If you were to not do a fantastic job of ventilation until a second person got there, that wouldn't be all that bad, as long as you're doing a very good job on getting the AED on and doing compressions. So it's very difficult when you're by yourself with cardiac arrest, and we need you to have the priorities in mind: AED, then compressions, and then do the best you can with ventilation. Now, if you come in with a team of 2, we should get compression started right away, immediately, while the second person works around the person doing compressions to attach those AED pads. And, open the lid on the AED, let it warm up while you're attaching the pads, and compressions are going on the whole time. We don't pause compressions until the AED tells us to stop compressions and stand clear while it assesses or analyzes. Once that AED is on and assessing, then you've got time to get your orals and nasals and your bag valve mask and your O2 and all that sort of thing ready. And in this case, one team member is going to hold that airway open and get that mask seal. That's a full-time position. They're going to position themselves at the head. They're not going to worry about squeezing bag valve mask or squeezing chests. The second team member is the chest squeezer, and then during the pause after 30 compressions, then the chest compressor is going to be the BVM compressor. So you're either squeezing or you're holding airway. And this is how we can use a bag valve mask that is a 2-person tool when we only have 2 people total to work the arrest. Now, when you walk in the door with 3, or as soon as a third arrives, now everything can just happen faster. It's the same priorities. It's get compressions going immediately while someone gets the AED attached and then drags all the ventilation stuff out. But if you have 3 people right off the bat, or a third person comes in shortly afterwards, then we can just move faster on this whole thing. In this case, now you've got a person at the head holding the mask and holding the airway, and then a person located on either side of the chest. So there's one of you on both sides of the chest, and you can easily just switch off doing compressions, and that third person can squeeze the bag in this case, if there's not other things that are pressing to get done. Other things meaning a scene safety concern, a family concern, moving furniture, that sort of thing. But if we've got 3 that can work on the cardiac arrest patient, put one on the chest on one side, one on the chest on the other side, and one dedicated to holding mask seal, and that will work best. Once a 4th or additional rescuers arrive, we have the same configuration. One's on the airway and mask, one's squeezing the chest, one's the relief chest compressor and can work in the bag, and then you have additional people to handle all those other duties, scene safety, logistics, moving things, getting some history, dealing with family, helping them understand what's going on, assisting the medic unit as they arrive with all their equipment, all those sorts of things. So we need 3 working the patient directly, and then we need additional people to handle these additional duties. So one of us has to be the incident commander. Who's the best for that? Well, it's up to you. It's up to you guys to decide that on the scene. It's not something we're going to try to prescribe. But the suggestion is that the person at the head doing airway and mask seal is able to look around and has the ability to size up the scene a little bit more than the person doing compressions, who needs to be focusing on what they're doing, or the third person who's watching with compressions and working on ventilation. So it's probably the same for a team of 2 or 3. It's probably the mask seal person. Then once that 4th person arrives, then you may be able to have them handle the IC duties, or based on who's who there, you may want to switch them out, assign them into one of the direct patient care roles, and then that IC person step back and handle all the other duties. When the ambulance service gets there with the paramedic crew, what do they want to know? Well, they usually want to know how old the patient is and what their history is. They want to try to determine what happened, how long they've been down, was there any CPR prior to our arrival. They want to verify that there are no contraindications to us working this cardiac arrest. It's easy for us to jump in when we're by ourselves, or there's just a couple of us there, and miss some lividity, even miss some rigor, or it just escapes us to ask about a DNR form. It's a very chaotic thing for the family, and so we just need to confirm that. And then they want to know if the AED shocked the patient. They're trying to size up what they're going to do in the house, what they're going to do during the transport, or if there is a legitimate reason why this code should be terminated at the house. So we want to try to provide them with that information, or at least be ready to answer their questions when they come in the door. As we know, every ALS team has the prerogative to handle things however they would like to, and there's probably a lot of variation out there in terms of how they do things, but one of them will have to be the team leader, and that person will typically handle the monitor, the cardiac monitor, and assess the rhythm, because that's what drives treatment. And that person is typically also a good one to give medications. So that person will typically position themselves at the hips or legs and watch the monitor and give medications and direct the team's actions. And then the partner of that team leader may be an EMT or maybe another paramedic, and so depending on which they are, that depends on what they're going to do. The paramedic partner will likely move to the head to do airway stuff. The EMT partner may be assigned various different things by the team leader. So there's a lot of variability in it based on staffing and personnel and personalities. And so we just need to do the best we can to figure out what's going on, always ask what's needed, and be as helpful as we can in every situation. But in general, we're going to end up making room at the head for somebody, and we probably can expect that the team leader will position themselves somewhere around the hips or south of there a little bit. Okay, last thing is traumatic arrest. Again, we can't always tell whether it was trauma that caused the car crash or the person had a heart attack and then they crashed. So we can't totally say that something is a traumatic arrest or a medical arrest in many cases. Survivability chances for blunt and penetrating trauma are exceedingly low, and the only hope is to get that patient emergently transported to the trauma team. These people don't get fixed on the scene, whereas medical cardiac arrest may have as good or better treatment on the scene than trying to move and do ineffective CPR on the move and make a very chaotic resuscitation. With trauma, there's no reason to stay. So anything that we do to slow down a rapid transport is bad. We should use chest compressions, we should use the AED, we should use ventilation, but we have to move fast no matter what. Traumatic cardiac arrest is treated in trauma centers, not in living rooms.